The growth of technological advancement these days has increased, and we are talking actually about the minimal invasive technique in dentistry in all specialties, in endo, in pedo, in ortho, in prosto, and especially in our specialty in implant surgery. We are talking about the digital implantology to place the implant with minimally invasive surgery, and also in bone grafting. We have several techniques to treat the bone resorption after tooth extraction, when the remaining bone volume is not enough for optimal rehabilitation. Also, with the same technique, the minimally invasive surgery. All of these technology to decrease patient dental anxiety from dental treatment, because we know all that several studies and articles demonstrate that more than 50% of patients have some degree of dental anxiety, especially in surgery procedure. So with the new technology and with minimally invasive surgery, we can decrease patient anxiety. These developments in dental implant technology induce the patient to demand more and more about implant procedure. That's why we have more than 150 implants company in 2020 and more than 200 implants brand in 2023. The dental implant global market in 2023 shows us a curve still increasing from 2020, and we expect this curve still increasing until 2030. Why we expect this curve still increasing? We expect this curve still increasing from 2020 until 2030 because the surgeon wants to decrease surgery time and decrease complications and patient discomfort after surgery. And the patient wants today to replace the missing teeth or missing tooth by an implant, with decreasing the discomfort after surgery and decreasing healing time and the chair time. Even in bone grafting, the patient is asking us always about the post-op complications and the healing time and the procedure, and especially when we explain to him that we are going to use the technique minimally invasive surgery. I like what John DiPonziano said. The success that modern dental implants enjoy today is surely linked to our ability to grow bone. And I can add using the technique minimally invasive surgery. So in this presentation, we're gonna talk about the lateral bone augmentation using the OssBuilder. When, how, and why. It's gonna be the part one. Why the part one? Because in this part, we're gonna talk about the surgery procedure of this technique to using the OssBuilder. And the part two, we're gonna share our clinical cases after connecting the prosthesis, results after 1 year, 1.5 years, and after 2 years. So 1 year after dental extraction, we have 25% of bone volume decrease, mainly in the buccal, lingual, and palatal direction. Like we have here, we have bone resorption after dental extraction. We have concavity, and the patient comes to treat to replace the missing teeth by putting an implant. This resorption was demonstrated by the famous experience made by Araujo 2005. The experience was made on dogs, and he demonstrated for us that the reduction of the ridge was greater along the buccal surface than along the lingual and palatal surfaces. So this bone resorption had many consequences on alveolar bone loss, on aesthetics in the anterior region, interferes with the placement of implants and influence the treatment success of fixed or removal dentures, incorrect 3D positioning of an implant, inappropriate restoration implant alignment, and difficulty for the restorative treatment. To prevent the bone loss, I use two techniques, the socket preservation technique and the immediate implant placement. For the socket preservation technique, this technique attempts to prevent bone loss by bone grafting the socket immediately after extraction, like we have here. For example, after extraction premolar and molar, we don't have a primer stability to put an implant. We graft the socket by bone material, and we cover all the surgical defects by membrane. Suture. After 6 months, open again and put two implants. The second, immediate implant placement. In this case, for example here, we have to extract the lateral central canine, the open flap. We have primary stability. That means we can put the implant, but we have to fill this gap with bone grafting, with bone material. And then we recover all the surgical site by membrane. This technique, after tooth extraction, helps to preserve alveolar bone height and width with reduced marginal bone loss. But you know, in most of our cases, the patient present with bone resorption to place an implant, like this CBCT here, the upper jaw, the lower jaw. Most of our cases, the patient comes like this, severe bone resorption, and he wants to replace the missing tooth, the missing teeth by an implant, and he asking us for a fixed prosthesis. All the literature agree that more than 40% of osteointegrated implants require bone grafting. And we have various augmentation techniques, and all of these techniques have an impact on bone regeneration. We have two ways to proceed. The first technique, for example, like we saw here in this photo, GBR while implant placement. We put the implant in the right position, and then we make the bone grafting. We put the bone material, and we graft with membrane. We cover with membrane, and we make the suture. After 6 months, open again, and proceed to the crown. For this technique, the second technique, delay to put the implant. We can make the bone grafting using autolog, heterolog, alloplastic material, then cover with membrane. After 6 months, open again, take off the screw, take off the membrane, and put the implant. Close. After 2 months, open again and proceed to the crown. But all the literature agree that the use of autogenous bone graft still remains the gold standard. If I have to compare between these two techniques, delay implant placement, to delay the implant placement, or the GBR technique, put the implant at the same time, put the grafting material. For the first technique, I have to use the autogenous bone block, the gold standard. I open a flap after lateral extraction, severe bone resorption, take a blown block from symphysis or from ramus, graft, and fix with the screw. Close. After 6 months, open again, take off the screw, and put the implant. Close. After 2 months, proceed to the crown. For the second technique, making the GBR while implant placement, like we show here in this clinical case, I have severe bone resorption after tooth extraction. Open a flap, severe bone resorption. I put an implant in the right position. I fill the gap, or I restore the ridge with bone grafting. I cover the surgical side with membrane, and I suture. After 6 months, I open again. Like here, for example, I can take a connective tissue from the palatal to increase the width of the gingiva, and then proceed to the crown. The difference between the bone block, the autogenous bone block, the gold standard, and the GBR, we know all. Then we have to use the bone block, the autogenous bone block. We have more positive results. We have horizontal bone increase, more rapid integration, optimal bone density for implant stability, vertical bone increase. We have stability of the block during healing and reduced bone loss, but we have morbidities and complication. And in this technique, it's 2-stage surgery and 2 surgical sites. For the GBR technique, we know that we have less positive results than the bone block, but in this technique, we have less morbidities and complications, and it's 1-stage surgery and 1 surgical site. In bone resorption, we have bone resorption after healing. For using the bone block, we have resorption after 5 to 28%. In the GBR technique, for many authors, we have 40% of horizontal bone graft loss. For Urban, he had mean crystal bone width increased from 3.2 millimeters to 6.9 millimeters. So we have several augmentation technique proposed to enhance the outcomes of atrophic jaw reconstruction. Many articles were published to talk about the bone augmentation, but all of these techniques are traumatic and aggressive for the patient. What the patients need now, what the patient is asking you now when he visits you, he is asking for one-stage surgery, reducing surgical intervention, reducing cost, reducing healing time, and shortened treatment time. That all lead for greater patient comfort and increased patient acceptance of implant treatment. That's why we expect this curve is still increasing until 2030, because the patient will demand more and more about the implant procedure. One of the techniques using the minimally invasive surgery that allows gain and maintenance of bone tissue is the GBR technique. We know it all, the guided bone regeneration. Studies for the past 60 years show us that when we have to use the occlusive membranes in association with bone graft material, we have gain of bone tissue. The guided bone regeneration is a successful, well-documented, and widely used procedure for treatment of alveolar bone defects in conjunction with implant treatment. A systematic review report, 95% implant survival after horizontal or vertical GBR procedure. Several reports have indicated that the implants placed sites augmented with GBR, it's the same implants placed in pristine or perfect sites. What is the GBR? You know all. We know all what means GBR. Guided bone regeneration, like we saw here in this photo. Severe bone resorption after tooth extraction, and we have to put an implant. We can put the implant because we have the primary stability, and we will have exposed threads because we have severe bone resorption. We should cover our exposed threads with bone material, bone grafting, and we should cover all our surgical side with membrane. We have many membrane, resorbable or non-resorbable membrane to cover our surgical side. But to use the membrane, the ideal membrane should be, we know all, we talk about biocompatibility, not being toxic, occlusivity, graft stability, space maintenance, support the blood supply, and permit the proliferation of osteoprogenitor cells. But we know all, when we have to use the collagen membrane without titanium reinforcement, tend to collapse. That means lose the volume in large reconstructions because they do not have adequate resistance to space maintenance. Like we have here, the patient comes to restore the lower jaw, the right lower jaw, and on the CBCT we have severe bone resorption, but we can put the implant, we have the primary stability. We open a flap, we put the implants, we have our primary stability, and we have exposed threads. We cover the exposed threads by the bone material, and we covered all our surgical side by the collagen membrane. And after 1 year, we will have a collapse, lose the volume, because we use the membrane without titanium reinforcement. Second case, missing central, open flap, severe bone resorption. We make bone grafting, bone material, covered with collagen membrane. And after 1 year, we have loose volume because we use the collagen membrane. Studies show satisfactory results for bone reconstruction with titanium or PTFE mesh. Maintain volume during healing period without graft compression by flap. We have here used, for example, the titanium membrane fixed with a screw, fixed with pins, or PTFE membrane. And after healing, we have maintained volume during healing period without graft compression by the flap. So we should cover the surgical defect by any kind of membrane, resorbable or non-resorbable membrane. Cover the defects with no stabilization. We have bone gain maximum 87.6%. So we should stabilize the membrane when we have to cover the surgical site. And when we have to cover the surgical site with the membrane, and when we have to fix the membrane, we should open a large surgical site. We should open a large flap. Look here, you open buccal flap, a large surgical site, and you open palatal flap to put the bone graft, to recover with titanium membrane and fixed with a screw or pins. Sometimes we use the mullet technique. It's very aggressive for the patient. Here we open buccal and lingual flap, large surgical site, buccal and lingual, to fix the membrane with pins or with a screw. But we have talked about this later. What the patient needs now? The patients need one-stage surgery, reducing surgical intervention, reducing cost, reducing healing time, and shortening treatment time. That's all lead for greater patient comfort and increased patient acceptance of implant treatment, and especially when we have when we want to explain to the patient, we have to use the minimally invasive surgery. So what we need? We need OssDem offer us what we need. OssDem offer us the OssBuilder, called the Smart Builder. It's a titanium mesh membrane. It's a bolt to promote bone formation. The OssBuilder is a titanium mesh membrane. We know all that the titanium alloy is a bioinert metal, excellent mechanical properties. Its rigidity prevents membrane collapse and provides space maintenance. In a study made on rabbit, show us that when we have to use the titanium membrane, that lead for higher degree of bone regeneration compared to other membrane related to the space maintaining capacity of the titanium membrane. When we have to use other membrane, we have exposure of the membrane, lead for infection, because we can have, for example, when we have to close, we can have more membrane exposure. That's not the case with OssBuilder. Why? Because with OssBuilder, it's 3D preformed design, does not require trimming or bending. External form round to avoid damaging of the flap that we have here. The surface smooth to avoid bacterial colonization of infection. Limit second stage surgical procedure, minimal incision. We're gonna see now in clinical cases how we're gonna take off, how we're gonna, it's so simple to take off this membrane with minimal incision. That lead no increased patient morbidity. So the OssBuilder mesh comes in 3 types of preform configurations based on the anatomy of the defect. We have type 1, that means one wall defect, type 2, two wall defect, type 3, three wall defects. We have different form. The first one wall defect for buccal defect. When we have one defect, we can use this membrane without releasing for less post-op swelling. Second membrane, two-wall defect. It's for buccal and proximal defect. We can use this membrane with minimum releasing. The third form of membrane, it's a three-wall for buccal, proximal, and lingual defect. We should use this membrane with releasing incision. So we have different form of the membrane, and we have different size of the membrane. We don't have one size, different size of the membrane. In surgery, how we can choose our membrane? When we open the flap, we can check our surgical site. Take the measure, proximal, buccal width, buccal length, and check our surgical site. If we have one wall defect, two wall defect, three wall defect, and we choose our membrane. We put our implant, like we saw here in the photo. We should have our primary stability. Then we connect the anchor. We put our bone grafting. We put our graft material. Then we fix our membrane on the implant by the healing cap or cover cap. We don't have to open a large surgical site, buccal or lingual, buccal or palatal, because we don't have to fix this membrane with a screw or with pins. We're gonna see now a video provided by Ostem explain how to use this membrane. The implant, the Ostem implant, we should put the Ostem implant. We open the surgical defects. We check our surgical defect. We put our Ostem implant, TS3 fixture. We disconnect the mount. We check our surgical site. We take the measure, proximal, the buccal width, and the buccal length to choose which kind of membrane we have to use. We have to use here, for example, the membrane 3-wall defects. So we connect the anchor or the height, bone grafting material, and we connect the OssBuilder by the healing cup. We put it, we cover all the surgical site, and we adapt, it's well adapted on the surgical site. We connect with healing cup or with cover cup. It depends of your surgery. No need for the large surgical site, buccal or palatal, buccal or palatal. And when you have to remove it, it's so simple to remove this membrane. So this is the clinical case. We have here, for example, concavity after tooth extraction, resorption, and we have to replace by an implant. I open a flap, severe bone resorption after tooth extraction. I put an implant at the right position, right place. No need to open a palatal flap because I have just buccal defect. I check my surgical site defect. I choose my membrane for the buccal defect. I put my bone graft. I take the measure. I choose here 1-wall defect. I condense the bone and I cover all the surgical defect by this OssBuilder, 1-wall membrane, and I fixed with the screw. I fixed with the healing cup. No need to fix with the screw or pins. No need to open a large surgical site. And I close the healing after 6 months. Second surgical case, we have to compare between two cases. The same thing, the same surgical case. We have to make horizontal bone graft. For the first one, we make it like a conventional technique or traditional technique. We open a large surgical site, we put the bone graft, we cover all the surgical site by the titanium membrane. We open a palatal flap, buccal flap, and we have to fix the membrane by screw or by pins. We close. After 6 months, open again, take off the membrane, take off the screw, take off the pins, put the implant, and close. After 6 months, after 2 months, open and proceed to the crown. The second case, the same case, clinical case, severe bone resorption after tooth extraction. I should replace the missing tooth by implant, open a flap, not a large surgical site, just here I check my surgical defect. I have proximal and buccal defect. That means I should use the 2-wall membrane with minimum releasing. That's why I will open a flap, buccal flap, just to see, to can put my implants, bone grafting, and cover all the surgical site with the OssBuilder. And I fixed with healing cup or with a screw cup. No need to open a large palatal flap because I don't have a defect, palatal defect. I close. After 6 months, open again, take off the membrane, take off the healing cap, and proceed to the crown. The third clinical case, here the authors show us that we can use the OssBuilder for one implant, we can use it for two implants, and we can use it for more than 5 implants like we have here. Here we have severe bone resorption for the upper jaw after tooth extraction. We treat it in conventional technique or traditional technique, make the horizontal bone grafting, covered by membrane, and close. Or we can treat it by using the OssBuilder. We open a flap, we have severe bone resorption, but we can put the implant, we have our primary stability. We put 8 implants. Surely we will have exposed threads because we have severe bone resorption. We cover the exposed threads by the grafting material, and we cover all the surgical side by the OssBuilder membrane. No need to fix by screw or pins. I fixed here just by the healing cup. Cover all the surgical defects by collagen membrane and close. After 6 months, open again, and this is the results. The author shows us that the hard tissue gain of all the sides was 3.1 millimeters, 6 months post-operatively. For other authors, this membrane, it's easily applied to different clinical cases. Other authors offer reliable and predictable results. For other, doesn't require bending or cutting, and also doesn't need a separate screw. For other author, even first-time users can expect predictable bone regeneration. For other, it's tailored to fit all types and size of bone because we have 3 different shapes and we have different size of this membrane. For me, I have 2 questions to answer. The OssBuilder can be an alternative method to the lateral bone augmentation while implant replacement. The GBR technique using the OssBuilder is effective and less invasive than other technique. I have to answer these 2 questions. I have to compare between these 3 cases. Severe bone resorption after tooth extraction. After open flap, the remaining bone 2 millimeters for the 3 cases. For the first case, I treat in conventional or traditional technique using bone block from ramus, from symphysis, and fixed with a screw. Close. After 6 months, open again, disconnect the screw, put the implants, and close. After 2 months, open again and proceed to the crown. Second case, remaining bone 2 millimeters. The same thing, horizontal bone grafting using autologous bone block from symphysis from ramus. I fix the bone block by screws and close. After 6 months, open again, take off the screw and put an implant. Close. After 2 months, open again and proceed to the crown. The third case, number 3. Look at the bone resorption. Very, very, very severe bone resorption. Look at the distance between the upper jaw and the lower jaw. I took my CBCT, very severe bone resorption after tooth extraction. Anterior side, 2.2 millimeters residual bone. Posterior, 4.8 millimeter. That means I don't need to make horizontal bone grafting posterior, but I should make my horizontal bone anterior side. But I have my primary stability. That means I can put my implant. And I decide to use the OssBuilder for horizontal bone regeneration with minimally invasive surgery. So I have here remaining bone volume 2 millimeters. I open just a very small flap just to can see to put the implants to make my bone grafting and cover with my membrane. Drill and I put my implants. I decide to leave 1.5 millimeters palatal bone and I have exposed threads 4 to 5 millimeters buccally. I check my surgical defects and I have to make my bone graft. So I check my surgical defects, graft the site, bone grafting 3 to 4 millimeters. I choose my membrane. I have palatal, buccal, and proximal defects. I choose 3-wall membrane. I fixed with the healing cup, and I cover just the buccal side with collagen membrane. I didn't cover the palatal side or the palatal portion of the membrane by a collagen membrane. I just covered the buccal side by collagen membrane. Then the releasing technique, and I close. The difference between the three cases. Look at the complication post-op. The patient, when I use the OssBuilder, intraoperative bleeding, it's normal. Case 1 and case 2, it's very important because I open a large surgical site. Soft tissue healing is the same. Pain scores and post-operative consumption of analgesic. The patient told me that she took every 6 hours 2 Panadol, 2 paracetamol. Case 1, case 2, they took analgesic plus anti-inflammatory drugs. Why? Because I open large surgical site. Swelling, the patient use OssBuilder. It's comparable to dental alveolar procedure. Case 1, case 2, it's very important because I open very big, very large surgical site. Major complication, no. Ecchymosis, the first one, no. Case 1, case 2, yes. 4 to 7 days. Donor site, no. For case 1 and case 2, yes. So, this case, the patient come after 8 months to check, to control the surgical site. Clinical exam. I took my CBCT for control, and I have 3.2, 3.3 millimeter bone gain. Here I had exposed threads, and I have bone gain, and I have bone outside the membrane. Look at the bone outside the membrane. This is the case. 8 months post-op, the healing, 3.2 millimeters bone gain, and I have bone outside the membrane. Decide to take off the membrane using the technique minimally invasive surgery. I start to open a very small flap. I use my blade number 11 for very precise and small surgical site. I want just to see the membrane, and I want to remove it and disconnect my healing cup. Minimally invasive surgery. I disconnect my healing cup and I take off my membrane. Look at the bone outside the membrane. It's so easy to take off the membrane buccally. And I have bone outside the membrane. So I take off my membrane buccally. Palatal. What happened palatal? I take off my membrane and I have a retention palatal. Why? Because I didn't use membrane. I didn't cover the palatal side by the collagen membrane. I had tissue invasion. That's why I have retention. So this is the results, the bone grafting after 6 months, and this is the membrane after removing. Healing. And here, clinically, I check clinically the results. I have 4 to 5 millimeters bone gain after 8 months. I have 4 to 5 millimeters bone gain because I have bone inside and outside the membrane. So to increase the hard tissue gain rate, Dallin showed us since 1988 that test sites covered with collagen membrane healed completely with bone. The control sites without collagen membrane, we have fibrous tissue invasion. So to prevent bone resorption during healing period, we should use a membrane. This membrane stops the tissue invasion. So I made here my self-experience. I cultured the human fibroblast on the dense membrane, and I observed the cells proliferation at 7, 10, and 25 days. Look, at 7 days, I had 1 fibroblast, 10 days, 1, 2, 3, 4, 5, 6, 7 fibroblasts. At 25 days, I have many fibroblasts. But look at the cells still remain at the surface of the membrane, cannot go inside. That's why we should cover our surgical side. We should cover our titanium membrane with collagen membrane to prevent the tissue invasion. And this was demonstrated by other article. The preformed titanium membrane should cover by collagen membrane to limit the tissue invasion. And if we have to use the titanium membrane or PTFE membrane, it's better to cover with collagen membrane. Covered control size demonstrate incomplete bone regeneration. We will have this. We will have bone, but we will have bone exposed. We should use a cross-linked collagen membrane for late resorption. Test site without collagen, we will have bone regeneration. This is bone regeneration. We have tissue invasion inside your surgery. It's better to cover your surgical site, to cover your OssBuilder, your titanium membrane, collagen, to get bone healing. This is the OssBuilder provided by Asst. The OssBuilder provided for Asst, it's a porous membrane. We have two different sides of pore. The 1 millimeter membrane, porous membrane diameter, and 0.6 diameter. Two pore, and each pore has its proper indicator. Many articles were published to talk about the role of the membrane. The precise role of the membrane porosities of barrier function of GBR membrane still awaits clarification. Different size result in difference in the intensity of the bone regeneration process. In animal study show us the macroporous membranes lead for greater bone regeneration compared to microporous membranes and prevented scientific soft tissue ingrowth. The pores allow neovascularization and bone formation. Differences in the intensity of bone regeneration were observed depending on the pore size. Pores exceed 0.1 millimeter required for the rapid penetration of highly vascular connective tissue. The small pore tend to penetration of capillaries. Other articles show us that the macropore enhance bone regeneration, but allow non-osteogenic cells to penetrate into the grafted region, leading to soft tissue incorporation. Other articles using different pore diameter, regardless of the combined usage of collagen membrane, yes or no, the conclusion was the titanium mesh pore size may influence on bone quality. They demonstrate for us also the large diameter pore size lead for a new bone regeneration. The small diameter, completely occlusive mesh restrict fibrous connective tissue invasion. And many articles show us using different diameter of pore size. The conclusion was the macroporous promote bone regeneration, the less porous preserves the osteogenic components in the defect space. For me, what is the best membrane pore? I prepare my self membrane by the hub technique. I did my self experience. I prepare 4 different membrane pore size, mean pore diameter 490 until 1720 diameter, micrometers. And I grafted this membrane into the back dorsal of the rats. And I made my biopsy at 7 days to check the cell invasion inside these membranes and to check the collagen fiber synthesis using the Sirius red on optical microscopy and on polarized light microscopy. I observed well-oriented collagen fiber synthesis in E1 and G2. What was the conclusion of my study? That the ideal pore for cells invasion and tissue fiber collagen synthesis were 0.7 and 1.075 millimeters, which in accord with other articles and in accord with the pore with the OssBuilder, Ostem titanium mesh. It's 1 millimeter and 0.6 millimeter. With me, I have my result 0.7, 1075 millimeters, With Ostem, it's 1 millimeter and 0.6 millimeters. We had the same results. So after this experience, after these articles, it's safe and comfort to start using this membrane. We're gonna share now many clinical cases using this OssBuilder. The first one, we have this patient comes 55 years to restore her upper jaw with implants after tooth extraction and after severe bone resorption. So the CBCT, we have remaining bone 2.9 millimeter, posterior region 5.1 millimeter. That means posterior region, no need for horizontal bone graft. Anterior region, I should make my horizontal bone graft. So I decide to use the OssBuilder for lateral bone augmentation while implant placement. I open very small largical site just to can see, to can put my implant, to can make my bone grafting, and to cover my surgical site with my membrane. So I put my implant, I have exposed threads, I check my surgical site, and I decide to use the 3-wall membrane, titanium membrane, with releasing. It's because I have buccal, proximal, and palatal surgical defects. I make my bone graft. I choose my membrane, my titanium membrane. I cover my surgical site with my membrane, and I fixed with the healing cup. And I cover my palatal portion of this membrane by a collagen membrane, and I cover my buccal membrane with a collagen membrane. 2 weeks post-op, 4 months. At 8 months, the patient recome for control. I took my CBCT. I have 3.1 millimeters bone gain. I tried to open, to take off the membrane. I use my blade 11 for very, very small surgical site. I just want to open, just to can see the membrane to take it off. Very small defects, very small flap. This is the membrane. I can see it. And it's so easy to remove it because I cover it with collagen membrane. I disconnect my healing cup. And this is my membrane. I start like this, and this is my membrane with all the connection. This is the healing. I have 4 millimeters buccal bone, gain bone. Sorry. Put the healing abutment and send it to the prosto. Second case, very, very severe bone resorption for the lower jaw. We make my CBCT. In the anterior region, I can put my implant. Posterior region, I have severe bone resorption. I can treat it by the conventional or traditional technique, horizontal bone graft and covered by membrane. After 6 months, open and put my implant. Or I have my primary stability. I open my flap, check my surgical site, put 2 implants with exposed threads. I choose here 2-wall membrane because I have buccal and proximal defects. That means no need to open lingual flap. I put my bone graft and I cover my surgical site by this membrane and I fixed by the healing cup. And I recover all my surgical site by collagen membrane. How we do proceed clinically? This is our patient, 44 years. She comes to restore her upper jaw. We have, sorry, we have missing molar. We make our CBCT on 3.5 millimeters, posterior 4.3 millimeters, and 5.9 millimeters. That means we don't have to make bone grafting posterior side. Just we need to make bone grafting in the anterior side. So we start incision with minimally invasive surgery. Open a flap just to can see the surgical, to can put the implant and to make our bone grafting and recover with membrane. Open flap, put our implant on the side, right side. We put here our first implant, second implant, third implant. Then third, check our surgical side, look at the exposed threads, decortication using 2 mm drill. We check our surgical side, surgical defect, we have exposed threads, we choose our membrane. 3-wall defect because we have buccal, proximal, and palatal defects. We open very small palatal flap just to put the palatal portion, and we connect, we fix our membrane with the healing cup. We check the membrane stability. We can raise it up and we can put it down. The membrane cannot move mesially or distally because we fix this membrane. We raise it up and we put it down. And so we start to make our bone graft. We put our bone material, and here, after finishing, we close. And we have to cover all the surgical side, and we have to remove all the bone excess. And we recover all the surgical defects by collagen. The results after 10 days. Another clinical case, 55 years, very severe bone resorption. He wants to restore his lower jaw. Region 6.5, 3.5, and 10 millimeters. No need for a horizontal bone, anterior and posterior. Open flap, minimally invasive surgery. Just to see, you can put the implant and make my bone grafting. Put the implant and check my surgical defect. Here I have buccally. I have exposed threads buccally. I choose the buccal. I have one surgical defect buccal. I choose the membrane for one defect. That means no releasing incision. Here I connect the anchor and I fix the membrane by the healing cap. Then I proceed to bone graft. So after all of this, I can say I have comfort and safety to use this kind of titanium membrane. What the dentist or the surgeon need? So the surgeon need to decrease healing time, decrease surgery time, decrease patient discomfort after surgery. And the patient, what he needs to decrease chair time, decrease his discomfort after surgery, and he needs one-stage surgery. We know all in medicine, we know this code. I hear and I forget. I see, I remember. I do, I understand. So this is my presentation. This is my experience with OssBuilder. You have now, you hear my presentation and you can see it, but you have to use the OssBuilder to understand what I explained. Thank you all. Thank you, colleague. And I'm waiting for your question.
Thank you, Dr. Wassim, for this very nice presentation. And now it's time for the questions. If anyone has any question, please write it down in the chat box. Okay, but initially we had, I received some questions. Is it always recommended to use a resorbable membrane on top of OssBuilder? I think this question was received a little early because Dr. Wassim already explained about it.
Yes, we explained too much about this. It's better to cover our titanium membrane with the collagen membrane. It's better to increase the hard bone results.
Okay, so Okay, we got another question about what is the amount of bone gain?
What is
What is the amount of bone gained?
the amount?
Yes, yeah, how much bone we will gain from the using OssBuilder?
It depends. 3 millimeters. The minimum bone gain I had is 3 millimeters. The minimum. With my
Mm,
experience, it's a 3.1, 3.2 millimeters bone gain, and this after 1 year.
Okay, we also have another question. Can we use PRF over it?
I didn't try it. Why you have to use it? We are talking about minimal invasive surgery. That means you have to reduce chair time and reduce surgery to the patient. Why use the PRF? It's a traumatic and aggressive technique. Why we have to use it?
Mm.
And
Yes.
the PRF, I think, need releasing incision. And we are talking no releasing incision. We should decrease the chair time, decrease the discomfort of the patient. Why use the PRF?
Okay, we got another question. What are the chances of this OssBuilder membrane exposure during healing stage? So how will you
Yes, I
manage
have.
it?
Yes. In my experience, I had 3 times membrane exposure. When the patient visit me after 1 week, I have 3 cases with membrane exposure. Just I make a suture again, and I had positive results after 4 6 months. When we put the collagen membrane, and if the membrane will be exposed, it will be safe. That's why we should cover by collagen membrane.
We also got
Any
a
contradictions
question.
to use this membrane? No, no contradiction.
No contraindications.
No contradiction. Just like I say, we have indication that means we should have primary stability to put to fix the membrane on the implants.
Mm, okay.
We cannot use it without implant. We should fix it on the implant. This is the main thing,
Mm.
or this
So
is the
we
aim
should
of
have.
presentation. This is the aim of the presentation. We don't have to open a large surgical site. We fixed on the implants. We don't have to fix with pins or with screw. That's why we don't have to open a large surgical site.
So basically, we should really care for the initial stability. Okay, so what is the exposure percentage? Is it like 40%?
I should be it's less. We don't have exact the percentage of exposure of this membrane. We don't have many cases because when we talk about 40%, you should make your statistic study. We don't have many results to make our statistically study, but I think it's less because I exposed the form of the membrane, the round shape, the smooth surface of the membrane. I think it will be less. And with no releasing flap, I think we will be no exposure
Mm.
because it's very minimal invasive surgery. We don't need to open a large surgical site. No swelling. Remember, no big swelling. After a large flap, we will have swelling. Here, the swelling is we have less swelling.
Here we got, I think this is the last question we have, is what is the role of the small holes in OssBuilder? It seems because we have a big holes and small holes.
Yes, we have two kinds of walls. The second one to let the first one, the 1 millimeters, let the blood goes inside. But because we need blood supply for the graft, you know this. And the small one to stop the bone goes outside. This is the principal role of the two diameters.
Okay, so I think we have got all the question answered for today. So, and we thank you very much, Professor Manhal, for your interesting lecture. I'm sure we all learned a lot today. And
So I want to thank you, Dr. Stephen. I want to thank you. First, thank you for Mr. Dahir. Thank you for Dr. Rashmi. Thank you, Dr. Stephen. Thank you, Austin team. Thank you, dear colleague, to attend this meeting. And see you for the part two of this presentation. Hope to see you part two. Thank you very much. Thank you all.